on stroke syndrome. We are very privileged to have with us one of the most renowned neurologists, Dr. Bindumenon, ma'am. Ma'am is the head of department and senior consultant neurologist, Apollo Hospital in Nellore. Ma'am has a teaching experience of 18 years and has over 70 publications in various international and national journals, presented over 100 papers, and has 14 chapters to her credit. Ma'am has organized 15 conferences with 16 credit hours from the Medical Council. Ma'am has fellowship from 4 national organizations: Geriatric Society, Indian Academy of Neurology, Indian College of Physicians, World Stroke Associations. Ma'am holds various posts like the Research Committee member of the World Stroke Organization, Indian Subcontinent and Epilepsy representative in the special group on the neuroepidemiology of the World Federation of Neurology, Chief Editor Epilepsy India, Presidency Epilepsy Association Nellore. Ma'am has been a recipient of 18 international and 24 national awards for epilepsy and stroke care, which includes the prestigious International League Against Epilepsy of Leadership Award at Barcelona 2017, World Stroke Award under Individual Achievement category from the World Stroke Organization April 2018 at Montreal, and H.C. Bajoria Oration Award from Indian Epilepsy Association and Montreal on medal among others. Ma'am has founded the Dr. Bindumenon Foundation in the August 2013. She has been instrumental in starting novel projects for the first time in the country: Neurology on Wheels, mobile application epilepsy app Epilepsy Help for epilepsy patients, tele-awareness program, and stroke rehabilitation app for stroke help. Ma'am has also published several educational materials like books, pamphlets, and comics. With this brief introduction, I request ma'am to proceed with the session. Over to you, ma'am.
Thank you, Aishwarya, and thank you, Marina, for this kind introduction. Without much ado, let me share my screen. So we come to a little bit different topic, which we were taking earlier. We were looking at the anatomy and how the cranial nerves and the higher mental function. I think we finished too. While we were trying to complete all of that, Aishwarya just suggested that we would like to have some clinical syndromes to be discussed, and what best is, which is stroke syndrome. And as we are nearing the World Stroke Day and the World Stroke Month in October, I feel that's the apt one which all of you should be knowing, because learning the stroke syndrome also helps us to recognize where the patient, what is the etiology of the patient, how fast one should move, what are the intervention procedures that the patient might require well before and ahead of a scan, either a CT or an MRI, which the patient might have. So the clinical recognition of the stroke in the acute phase, it helps us to enable the diagnosis and obviously the exclusion of stroke imitators, because there are certain telltale signs. If the patient has, then we know that it is a stroke syndrome and it is not other mimics which we have excluded from the history itself, so that we do not need to chase them by investigation. It, as I said, it helps us in a large way to plan an acute intervention by localizing of the stroke. Now, each subtype of stroke benefits from intravenous thrombolysis. Now, we speak about a large vessel occlusive disease. Large vessel occlusive disease is a ICA occlusion or a basilar occlusion or an A1 of the anterior cerebral artery occlusion, M1 and M2 of the middle cerebral artery. So when we have these characteristic areas, if, for example, if we have a patient in the periphery and if we have a good stroke connect program, and if we have some signs on the patient, which the patient at the peripheral hospital, before the patient is shifted to the hospital, they tell us that the patient has got a severe deviation of the eyes to one side, the patient has got the limb paresis, the patient is aphasic, the patient is not able to comprehend, then we know that his cortical area is involved. That means that could be a large vessel occlusion for this particular patient, and the patient might require acute intervention, if not a thrombolytic therapy. If the time has passed, then we know that there are certain endovascular procedures which can help us. So stroke syndromes, even in the era of a good neuroimaging, one may feel that why do I need to know and learn the stroke syndrome? Even in the era of good imaging, we know that how fast we need to act for that particular individual patient. So it helps us to direct to the subsequent workup. Now we know that if the patient has got multiple areas of the brain which is involved, which produces a global sort of deficit in the patient, we find that the patient has got, once he gets had a left MCA infarct, then at one subsequent point of time he had a right MCA or a PCA, or that is a different arterial territory infarcts in that particular patient, tells us that there could be an embolic source, and we need to hunt more deeply for an embolus. Either it could be from the heart, or it could be from the vessel, which is if it is an aorta, then it could be a atherothromboembolic phenomenon. So you understand the patient has been multiple areas of infarction in multiple areas, multiple arterial territories. So it has to be some gush of emboli which is coming from either from the heart or from the aorta. So it could become a cardioembolic, or if it is an elderly person, then we need to find out whether the patient has got atrial fibrillation. So the patient would need a Holter monitoring. The patient would need a strict at least 24 to 48 hours of ICU monitoring to see for any fibrillation. It also allows the clinician to anticipate, recognize, and treat complications related to the specific stroke type, such as the large fluctuations in the lacunar capsular warning syndromes. So now if a patient has got hemiplegia, let us say, and it is in the internal capsule. We know that internal capsule, even though if it is a small area, all the corticospinal tracts go from that area. So even if a small lesion of the corticospinal tract is involved in a basal ganglia infarct, the patient can have a severe motor deficit, which can make him incapacitated for life. So you need to act very fast, because a small area looking on the scan, but we know that it is an internal capsule, the patient can go into 0/5 power in no time. Or we know that the patient has got a brainstem compression. The patient has got an unequal pupil. We have already seen that. The patient undergoes a CT scan, as we had told earlier that certain brainstem lesions are not picked up on a CT scan. So we know that if the patient has got lower cranial nerve palsies, the patient has got an unequal pupil, the patient's pupil is one pupil has got dilated and not reacting to light, then we know that there is an impending brainstem compression or a cerebral edema, and then the patient may require a neurosurgical intervention immediately, so as the patient does not have a brain death. So it helps us to make the correct diagnosis, meaning choosing the appropriate secondary prevention. That we will come, the patient has got a basal ganglionic infarct. We know that there are the small vessels, that is a lenticulostriate vessels, that is a lipohyonesis, which is very involved. So you're not going to chase a cardiac source of cardiac cause of stroke in that particular person. You'll need to find out whether he has got high sugars, which are not kept in control. His blood pressure is not very well in control. His lipids are not under control. So in the presence of a significant carotid stenosis, we also know that the patient needs to have an endarterectomy, carotid endarterectomy, if there is a stroke which occurred in the territory which is distal to the stenosis. But if the patient has got a right ICA which is stenosed, and the patient has got a left MCA infarct, we know that that is not the area which is involved, but then patient needs to be tackled for that particular arterial obstruction as well. So basically, a clinical syndrome diagnosis as soon as a patient gets to the emergency is very important, and there are some quick signs in the patient which we need to see to know whether it is an ACA, whether it is an anterior circulation or whether it's a posterior circulation. in the anterior circulation, whether it's an ACA, it's an MCA. In the ACA and MCA itself, we need to know whether they are the initial branches, that is a large vessel, that is the A1 or the M1 or the M2, or the distal branches. In the posterior circulation, we need to know whether there are any impending signs of a patient's brainstem death in that particular patient. So clinical diagnosis of the patient continues to take precedence, because that's before the patient is sent into a scanner, an initial judgment or clinical Am I audible? Somebody muted me.
Ma'am, you're audible, ma'am.
Yeah. I just saw a muted sign. Yeah. So this is a pictorial representation. You would see the blue is the ACA, the brown is the MCA, and the yellow is the PCA. If you will take a axial section of the brain scan, if you would draw two lines across, it will this cutting across to the anterior cerebral artery, and this is the posterior cerebral artery, and this is the MCA territory. So ACA, MCA, PCA. And you would also look at this picture here, which we can really see that the medial hemisphere is very predominantly supplied by the anterior cerebral artery. So that is the out portion, and this is the inner portion, if one would look by, and this is the axial section. And here, as we can see in these, that as I was talking to you about the M1, M2, M3, so you want to see that as soon as the branch divides, then it comes into this is the perforators, and these would be the peripheral, which we would come shortly. So the clinical circulation of stroke, we need to divide into the anterior circulation and the posterior circulation. The anterior circulation is the ophthalmic, the posterior communicating artery, the anterior choroidal, and the anterior cerebral, and the middle cerebral. We may not want to dwell into so deep into the branches, but then we will deal into the branches which are very significant, which are very obvious, and which needs to be known at the emergency as well as at the bedside level. The anterior circulation, we would divide into two. One is the leptomeningeal arterial system, in which one can say that they are more cortical. The leptomeningeal are more cortical. The deep perforating system, you know that the basal ganglia, the centrum semiovale, the internal capsule are very inside, like a apple here. And then we have the cortex here. So the leptomeningeal artery system will supply this, and the deep perforating branches are supplying the basal ganglia, the centrum semiovale, and the parts of the internal capsule. Now these ones, the deep perforating artery system, are more they would more have a syndrome of motor weakness in these patients. Motor, and if thalamus is involved, they will be more sensory. The leptomeningeal artery system would be more cortical. So we had learned when we were doing the higher mental functions that we learned that if the cortex is involved, we have more of language disturbance. Language, not speech. Speech would be there for both of them. This would be having language disturbance. So if a patient comes to you with, in an acute stroke, even the deep perforating artery, if the basal ganglia is involved, the patient can have aphasia. But if he has got a very gross aphasia, then the patient, we know that the cortical branches of the anterior circulation are also involved. So let us come to the MCA stroke. We know that the MCA strokes are the most frequently affected by the acute stroke. They could be subtle, or they could be a devastating clinical syndrome, which is depending upon the site of the occlusion. We mentioned the large strokes, where the involvement of two of the three MCA territories, that is the superior, deep, and the inferior divisions, are involved. And we call it as the MCA malignant territory infarct, when there is a complete occlusion of the MCA territory infarction with ensuing mass effect from brain edema. So just taking it back here, if you would say that if this whole area is involved, that means if this whole area is involved, this is the leptomeningeal part, which would be, as we spoke, and this is the deep perforating part. So if the deep perforating as well as the leptomeningeal, that is the whole of the MCA, is blocked, then we say it's a malignant MCA infarct. And for that matter, if the internal carotid artery, which gives branch to the MCA as well as ACA, that we say there's a malignant ICA infarct, then you can imagine the IACA part as well as the MCA part is involved. That is 3/4 of the brain of the patient. So you would see the consultants keeping on talking, that's a malignant MCA infarct, that's a malignant ICA infarct. The word malignant tending to denote that the patient has got a devastating stroke, patient has got an extremely large stroke, the patient can have mass effect, the patient needs to be monitored very carefully. And having said that, the outcome of the patient also is not very good in a case of a malignant MCA infarct. Now let us look at the individual branches of the MCA, because individual branches of the MCA also have clinical symptoms pertaining to that particular branch. So in an MCA, so this is it. This is the internal carotid artery. And from here, above it would go to an anterior cerebral artery. And from here, it goes into an MCA territory. So we have left off the AC territory here, and we are talking about the MCA. So this is the M1. So rightly pointed out here as a horizontal branch. So you can see the M1 branch and with the lenticulostriate arteries, that is a deep perforatus. As I said, if that is only involved, it becomes, it leads to the basal ganglia, internal capsule, and the corona radiata infarcts. Then we have the insular part of it, that this is the insula, that is the area of the speech, area of the language, and if that is involved, from here. Then we have the divisions, that is the opercular, and then we have the superior as well as the inferior division. So we know that the superior, this would go into the frontal, and inferior, it will go into the temporal. And depending upon which branch has been particularly involved, it will produce a frontal, as we had read in the first class, it will produce a Broca's aphasia. Or if it is in the lower division, that is in the temporal, it will produce a Wernicke's aphasia. Now, the whole stem is completely blocked from here, then the patient would have a global aphasia. How does this help us to know what is the cause of the stroke? As I said, if there are lenticulostriate arteries, the basal ganglion is involved. In most cases, the patient has got risk factors like hypertension, diabetes, age-related atherosclerosis, hyperlipidemia, and so forth of the end-on arteries getting involved. Now, if the patient has got a upper segment or the lower segment involved, so most of the times we feel that it could be a cardioembolic cause, especially if it is an elderly gentleman. It could be a lone atrial fibrillation for that patient, so it is very important for us to monitor. The patient presents with only a Wernicke's aphasia in an elderly man, and the patient doesn't have a characteristic history, has a hypertension which is extremely well controlled and not a diabetic, then one should also chase a cardioembolic, because in the initial assessment, the patient may not have a atrial fibrillation which is documented, because as I said, there could be an intermittent, that is a paroxysmal atrial fibrillation. So it helps us to also tell us the sort of chart out the investigations in a particular patient depending upon the segment. So we have M1, M2, M3, and M4. So the classical features of how a MCA infarction would be is a contralateral hemiparesis or a contralateral hemiplegia, a contralateral sensory loss, a contralateral homonymous hemianopia, an ipsilateral conjugate eye and head deviation, that is, the patient looks at his or head lesion. Left side would produce a comprehension defect, would produce a language defect, that is, he would have an aphasia. The right side, we have told that it will be more of perceptual defects, and then we had read about the neglect features in them. So if the patient has got a right-sided hemispheric lesion, so he would persistently have a neglect on the opposite side, that is, he would definitely not look onto the left side. So when you are assessing the patient, when you're talking to the patient, taking care of the patient, having a physiotherapy to the patient, you need to have stand on his right side to see that the patient understands, and not to stand on the hemi-neglect side. So M1, we'll go into a little deeper about how the syndromes of the middle cerebral artery infarct presents to us. M1 segment, if there is an occlusion of the lenticulostriate art branches, that is the internal capsule, the patient will have a pure motor or a pure sensory motor stroke in which the upper limb as well as the lower limb would be involved. The strength and the weakness of the upper limb and the lower limb will be almost equal. So there would be, we use the term a dense hemiplegia. Dense hemiplegia, the patient would present with 0/5 and equal upper limb and lower limb motor weakness. So sometimes in putamen or pallidal lesion, globus pallidal lesion, if the lenticulostriate arteries are affecting only that areas, the patient can present with a lot of extrapyramidal syndromes and can sometimes be difficult to judge that the patient had a stroke. It's very important for us to realize that it is not important that how big the lesion is. As I was saying, in a malignant MCA infarction, we are saying about the extent of the lesion, which produces catastrophic stroke. But in a basal ganglionic lesion, that is M1 syndrome, where the lenticulostriate arteries are affected, even if a small lesion here, as I said, all the corticospinal tracts are sort of concludes onto one point and they move out from there, then it is not necessary that the lesion needs to be very large on a scan. Even a small lesion, this deficit can be very severe. Goes to say that if the patient has a basal ganglionic lesion and if the patient has got a dominant hand and leg which is affected, or the patient's hand is just 2/5 weakness, and one needs to take a call on the thrombolytic therapy. One needs to understand if the patient has presented in a window period of stroke, the stroke can progress because we understand that the corticospinal tracts are so concentratedly kept there. The patient is an eligible candidate for intravenous thrombolysis. Patients with the lenticulostriate arteries, that is the end-on arteries with a hemiplegia of left upper limb, right upper limb, one side, there are no cortical signs. They're extremely minimal. Only if in an acute stroke for maybe for 24 hours, the patient may have cortical signs. Cortical signs meaning if it is a left-sided lesion, the patient has got aphasia. And if it is a right-sided lesion, the patient can have a neglect. So they're very absent or minor, and if at all present also, they usually subside after that. After this, that is the horizontal division, and that's what we are talking, and the lenticulostriate arteries. After that, the branches, the vessel branches into the upper division and the lower division, that is the superior and the inferior division. So we understand the upper division is frontal, the lower division is temporal. So depending upon the hemispheres involved, as we had again learned in our higher mental functions, the patient's presentation would be according to the lobe that is involved. So if the patient has only a superior division involved, so let us say there was a cardioembolic source there, the patient has a atrial fibrillation, one embolic source rushes from the heart, goes out into the ICA, does not go anywhere, and then goes and lodges into the superior division. So he would have only this part which is involved. You understand? So there is only the frontal lobe, the superior division, which is supplying. So in that syndrome, in that case, the patient has only, if it is a left-sided weakness, the patient has got only Broca's aphasia. And if it is a right-sided weakness, the patient can have an opercular syndrome. Opercular syndrome means the patient doesn't have an aphasia, but he's not able to use his lips, tongue for vocabulary. He would be eating, he would be doing everything, he might whistle also, but then he would not be able to use it. So sometimes patients come into the emergency, and because he's able to talk, sometimes he would, but be asking him to do something, he would not be able to perform well. So it is always mimicked like a conversion reaction. But then one should understand, that's why you need to know the stroke syndromes, because you know in your brain that it could be a frontal opercular syndrome the patient could have. So am I missing out the superior division of the MCA, where the patient has a little bit of hand weakness and arm? The inferior division supplies the temporal lobe. So if it is on the left side, the patient has a Wernicke's aphasia. We have learned about the Wernicke's aphasia. The patient's comprehension is poor. the patient has excess talking, the patient has logoria, has confabulation, and the patient need not have any weakness, and the patients sometimes can be extremely aggressive as well in the left-sided wernicke's aphasia, because they are not able to comprehend, they are not able to get out their demands in the form of language and speech. They tend to get extremely agitated as well. And the patient can have quadrantinopia, as we had seen that the four quadrants, the upper both sides, the lower both sides, but then that would be in the initial stages a little difficult to test. On the right side, again, there could be hemispatial neglect and a spatial agnosia without weakness. So the right side presents more of neglect symptoms, the more of either it could be a sensory neglect, it could be a motor neglect, or it could be a visual neglect. The left side presents to us more with, if it is a cortical branches especially, it presents to us more with language disturbance, with or without weakness of the arms and legs. If it is on the left side, it is a aphasia of Broca's or a Wernicke's, and even if there is a weakness, it is very minimal, and the weakness is not like which we had in a lenticulostriate, that is the branches of the M1, the upper limb and the lower limb. It is not a dense weakness. It is more on the brachial. It is more on the hand areas, which is that is involved. So you understand, if the patient presents with more of language, it's more on the cortical, that is a lenticulostriate. If the patient has more on the perforating arteries, then that would be difficult. This one. So there is something known as a Prevost sign, that is a Vulpian sign. It refers to a conjugate ocular deviation in patients with acute cortical hemiparetic stroke. You would see in patients, especially this is usually seen in the right hemispheric lesions, in which the patients have got a left side, which is they have a conjugate deviation. The conjugate eyes onto the left side are paralyzed. So they tend to look at the side of the stroke. So they will have this eyes which is going like this. Every time you ask them, yes, yes, what is your name? My name is this. Then again, they will keep going like this. Again, so you know that it is a large cortical sign. And especially that's why in our Stroke Connect programs, one of the column which we write is that, does the patient have an ocular deviation of the eye? So is the patient continuously looking onto the side of the stroke? And as I said, it's usually on the right hemisphere and very less on the left hemisphere, which will also come. Why it happens? Because in a normal individual, the left side subserves the functions on the right hemifield, but the right side also subserves onto the left as well as the right. So if there is a patient has got a right-sided lesion, then you can see that he is not able to take care of both. But if he has got a left-sided lesion, the right hemisphere takes care of both. So the neglect part is very, very predominant in a right hemispheric lesion, for the simple reason that the right hemisphere takes care of not only the left hemifield, but also of the right hemifield in a partial way. So the neglect phenomenon should not be missed from us. So a complete superficial MCA, which is sparing the lenticulostriate arteries, what would be the symptom be? The lower limbs are less than the face and the arms. So we have the face, that is a faciobrachial weakness in that patient. They can have just isolated language disturbance, that is the Wernicke's and the Broca's. As I said, hemianopia, that is homonymous hemianopia, or quadrantinopia. If only the temporal lobe is involved, then you have a quadrantinopia. Deviation of the eyes and head and eyes are very common. And cognitive deficits are similar to the M1 occlusion, but often less pronounced or rapidly improving. So thrombus in the distal part of the MCA at the bifurcation of the artery suggests strongly a cardioembolic mechanism, particularly in the elderly. So in a scan, one might find like this. This is the Wernicke's aphasia. That is, you can see that this is not the cut which we take for a, you can see the sylvian fissure below it. That is a temporal lobe, and above it, that patient has presented with a Broca's aphasia. So anosognosia would be very common in patient with a right hemispheric infarct. that is particularly in large right hemisphere strokes, which involve the parietal region. So we have done the MCA infarct, how the MCA divides into M1, M2, the superior, the inferior division, and how it takes care of each, and how the etiology would be different in both, and the lenticulostriate, how the limb weakness would be different in the M1 segment and the M2 and the M3, M4, and how the eye deviation and the head deviation of the body in some cases can help us to localize that the patient could be having a distal branch also involved. Now we come to the anterior cerebral artery. As we said, that ACA territory infarcts. Again, there are a lot of branches in the brain, as we can see that the circle of Willis is very nicely has been made by nature, so that there is such a collateral flow from one to each other, and especially in anterior cerebral artery. And that is why we see most commonly MCA territories rather than ACA territories, for the simple reason that there is this beautiful connection between the either sides of the anterior cerebral artery by the ACOM, that is a nature itself has provided. That is a collateral flow. So in case the patient has got a block in this vessel and the blood flow is not there, you can see that the patient will get a collateral flow and will have a perfusion of the right ACA frontal lobe as well. The same goes with the M1 and M2 also, but here the opposite side of the brain vessel takes care if there is a block. In here, in these cases also, sometimes the patients may have very good collaterals. What do we mean by collaterals is that there are a lot of branches onto these parts. So in case the patient has got a perfusion and a block on this area, sometimes the patient's deficits do not match. That is because the patient has got so much of collaterals, because the patient's atherosclerosis of the vessel was so, has been so, the pace has been so slow that the nature has given him time to make so much of collateral perfusion. Why that is again important? Because it helps us to know whether we can have the patient for an endovascular therapy, because if there is a block here and the surgeon puts the stent here and tries to retrieve the clot, if there are no collateral circulations here, then if the clot is trying to be retrieved here, then the patient can develop a devastating stroke. So collateral circulation helps us to take a call on the endovascular therapy as well. So the ACA territory, again, A1, 2, 3, 4, 5 is, so for our discussion, we will take only 2 points. Before the ACOM joins both the anterior cerebral artery, this is A1. After the ACOM, this is A2. And there is another recurrent artery of Hubner, because it supplies to the caudate, head, genu, and anterior arm of the internal capsule. Why that is important? Because the presentation is like an MCA, and the artery which is involved is an ACA. So what are the prototype features of an ACA territory infarct? As I said, ACA infarcts are rare because of the collateral circulation from the ACOM. The weakness is predominantly of the distal lower limb. What did we see in the MCA? If at all it is dense, upper limb, lower limb. If at all it is monoparesis, it is upper limb. If at all it is in the upper limb, it's mostly in the hands. It is a fascio and grip weakness. In ACA territory is predominantly lower limbs. The patient may present just with a foot drop. The face and arm are relatively spared, lesser degree of the upper limb. If at all the upper limb is involved, and in case the upper limb is involved, and the upper limb is usually involved, but usually there is a common mistake. If the patient comes to the emergency, he is made to lie down and is like, show me, what is your grip? Catch hold of my fingers, catch hold of my fingers. So that's what we do. Never ask the patient to lift the hand, and it's the proximal shoulder and the distal leg weakness. Why it is also very important? Because if the patient, let us say that the patient presents to you, presents in the emergency, the foot drop. How do we make out that the patient doesn't have has a CP common peroneal nerve, which is there's a pressure palsy. The patient has been traveling for a long period, the patient is an alcoholic, has slept and just woke up with a distal lower limb weakness. So it is very important for us to also check that the patient doesn't have a proximal shoulder shrug weakness. The leg weakness is more distally, and the patient predominantly has a hemi-neglect also. Usually the patient has got a transcortical motor aphasia, in which the repetition is very good. The patient is able to pronounce very long sentences, unlike in a motor aphasia, that is a Broca's aphasia. The patient speaks in monosyllables, and the patient is not able to repeat what you are able to say. The patient of a Broca's MCA territory infarct speaks only less. He speaks only words. He does not speak sentences. And if you ask him to repeat a sentence after you, he cannot repeat. But in a transcortical motor aphasia, the patient is able to repeat. The patient has can have behavioral disturbances as well. The sphincter, that is the bladder, as we have seen, the medial part of the hemisphere brain is completely affected in an ACA territory. The patient would be mute. He takes a lot of time to respond back and has amnesia and can have frontal release phenomenon. In some patients, if there are large symptoms, they are known as grasping or grouping. So they may not even leave your finger. If you have asked him to hold the hand, he will continue to hold the finger and would not leave your finger. So this is the ACA territory. So the other syndromes which you can have, this would be the area which would be involved in that. The other areas which can be affected in an ACA is the corpus callosum. So all of us understand the corpus callosum is the part of the white matter which connects the left and the right part of the brain. This corpus callosal strokes are extremely rare because it is perfused by multiple blood and territories, because it's perfused by the ACA territories, it's perfused by the PCA territories as well. So the classical syndromes of the anterior ACA territories, corpus callosal infarcts are extremely rare. But in case if they present because of the patient may not have a bilateral, it could be both the ACA territories would be branching from the single ACA territory. That's a paired one. It means the left and the right would be coming from the one single ACA territory. Then they can have a corpus callosal disconnection syndrome. So they don't understand from what is left to what is right. Why it is again important for us to know, because these patients' symptoms are a little bit bizarre, and the patient can look like a conversion syndrome, because the patient sometimes may not have a classical stroke syndrome of a motor or a sensory or a language or a visual. So that's the four categories we see. Whether the patient is a hemianopia, the patient's language is good, the patient has a motor, patient has a sensory, and then you look at the cranial nerves to see whether the patient has a posterior circulation. If all of these five are not involved, the patient can have sometimes in this corpus callosal disconnection syndrome, small frontal infarcts, and the patient may be having just a transcortical aphasia. The patient can become a little mute, may present just with a foot drop, then it becomes difficult. As I was saying, that a patient can present with the faciobrachial predominant hemiparesis. There is this artery which comes out, and we should know the name of this artery, because this is one artery which can be seen in our cath angio also. That is a recurrent artery of Hubner. And this is a classical area that is affected. And again, as I said, it's an ACA territory infarct. So we are not looking at an MCA territory infarct. So we are not looking at the lenticulostriate branches of these patients. There is something known as the pusher syndrome. You would see patients who are sitting on the bed, they would continuously tend to fall onto one side. But some of the patient, even though they have a dense hemiplegia, they would not be falling. They would, if you make them sit, they would be able to sit properly, and their sitting balance is extremely good. This all becomes very important for the treating physician, because this helps us to channelize our physiotherapy and rehabilitation process in the similar way. So it is a term which is used to describe the behavior of individuals using the non-paretic limb to push themselves towards the paretic side. So if they are left unsupported, these patients demonstrate a loss in lateral posture, falling onto the paretic side. So they will continuously fall. It is usually seen in the non-dominant hemisphere again, is often accompanied by severe inattention and hemisensory impairments. So the non-dominant hemisphere, though the patient doesn't have a comprehension defect, but you can understand the rehabilitation part becomes very difficult because he has got a lot of hemi-neglect, he continuously falls, he has inattention, he has anosognosia, he does not recognize his own symptoms, he may even say that that limb is not his own. So this is a pusher syndrome. He keeps pushing with this strong arm and he keeps falling onto the side. So you can see that it is very difficult for the nursing personnel or the physiotherapy person or any of the rehabilitation of the family member to keep him and take him, though he may be talking to us well, but to mobilize him becomes difficult. We might leave that. So now from the anterior circulation, we come to we are 45 minutes down the talk. So we will keep talking, Aishwarya, is that okay? And then we will wind up at 1 hour.
Yes, ma'am. That's absolutely fine, ma'am.
Yeah. So because stroke syndromes are very large, I do not want to miss out anything which could be very important for all of you. So now we come to the posterior circulation. Now, posterior circulation is very, as I said, one can always, if the stroke syndromes are seen in the way of whether the language is affected, whether there is a homonymous hemianopia, that is a conjugate gaze, that is vision is affected, the patient's motor symptoms, the patient's sensory symptoms, and then we come to the cranial nerve palsies. So when the patient starts, when you are looking at the patient, when this patient starts having lower cranial nerve palsies, from that we mean even the 7th lower motor neuron paralysis, the 3rd nerve palsy, the 6th nerve, and then the lower cranial, where it is dysphagia and everything are there. If the patient starts having that, then we immediately, our radars are on and we know that we are looking at a posterior circulation stroke. Again, in the posterior circulation, the P1 subserves the midbrain and the thalamus, and the P2 again goes to the cortical, temporal, and the occipital branches. So there are several syndromes which are described and which are not very important for us to learn by heart the syndrome names, but however, they have a lot of technicalities to it, which helps us to localize. So the patient presents to you with a gait disturbance and a 3rd nerve palsy, and you know that it is a cerebral peduncle and the red nucleus that is involved. The patient presents with a 3rd nerve palsy and a hemiplegia. You know that is a midbrain and a cerebral peduncle that is involved. The patient presents to us with a 3rd nerve palsy, hemiplegia, and ataxia, ataxic hemiparesis, then it's a red nucleus, medial midbrain. If there is a subthalamic nucleus, you know that the patient has got a contralateral hemibalism. And what is hemibalism? Is extreme flinging movements of the hands. You would see that the patient just presents like this, and it is an emergency presentation. For one, it looks very offensive for the patient to keep doing that, and it very difficult for the patient to stop it, and the movements are extreme flinging and can tend to hurt the nursing personnel as well. You know that characteristically it is a hemibalism, and usually the patients are diabetic to that matter, and it goes into the lesion of the subthalamic nucleus. So we have the classical thalamic syndrome, in which the patient presents with a hemisensory pain and hemisensory paresthesias and dysesthesias, which is excruciating, which involves the face hemi, the trunk, the upper limbs, and the lower limbs. And we know that it is a classical thalamic syndrome. So these are the areas where the lesion could be. The Weber syndrome, where we said the cerebral peduncle and the 3rd nerve nucleus. The Benedict syndrome, where the third nerve nucleus as well as the contralateral ataxia. Then we come to the peripheral branches. So in the, again, like in the MCA, there are the T perforators and the lenticular striate. In posterior circulation, PC artery also, there is a central and there is a peripheral. So the peripheral again will go into the lobes. That is a cortex. So it goes into the temporal lobe, it goes into the occipital lobe. So meaning once it has reached the occipital, again now we come to the vision. So there is a contralateral homonymous hemianopia. And unlike in a patient of an MCA territory, which has got a homonymous hemianopia, we know that it is one, a person is not able to see one side of the visual field, not one side of the visual field. So if he looks at this point, he cannot see. Even if he close this point, means he cannot see from this to here. So the patient presents with a contralateral homonymous hemianopia. It is severe than that of a patient with a MCA territory, in fact, in which the patient can have a quadrantinopia and little bit less aggressive. So the PCA territory patients come out with the history itself that they say that I'm not able to see one side of the vision, one side of the visual space. The patient can present with a sudden memory loss because the patient has got a hippocampal involvement also. The patient presents with a peduncular hallucinosis. He can see colored objects moving. The patient presents, if the patient has got a basilar infarct, patient completely becomes blind. And most of the times the patient becomes blind, the patient is taken to the ophthalmologist because the patient doesn't have a motor weakness. The patient doesn't have a sensory symptom. The patient presents with a sudden blindness, and it's thought to be an occipital, thought to be an ophthalmic problem, and is taken to an ophthalmologist. But a cortical blindness must be kept in mind when the patient has got a acute, sudden, bilateral visual loss, where the patient is still able to recognize by voice. Anton syndrome, the patient's unable to understand that the patient is blind and completely in denial, though they go and start hitting onto the furnitures in the house, but they say that they can still see, and the furniture has not been kept in the proper place. We spoke about the midbrain lesion. We spoke about the pontine lesion. We spoke about the thalamus with the hemisensory phenomenon. We spoke about the hippocampus, which can present with a sudden acute visual loss. The patient has having cortical features, that is the occipital lobe involvement with characteristic one side being a homonymous hemianopia, or if it is bilateral, the patient presenting with a complete blindness. The cerebellar strokes presents with ataxia. So if the patient has got ataxia, then there are ataxic syndromes which are there. So ataxic syndromes, first one should keep in mind is the cerebellum. But then the ataxia could also be from the pons, they could be from the medulla, they could be from the thalamus. But with that, they would have some other symptoms also. So if the patient has got a midbrain lesion and is ataxic, what did we see? The patient would have a third nerve palsy. If the patient has a thalamic syndrome and is ataxic, the patient will also have a sensory symptom. If the patient has got a medulla lesion, it is very, very characteristic. The patient medulla, as we have seen in the last class, the patient has got lower cranial nerve involvement. The patient will have an ipsilateral lung and gait ataxia, and would have a hemisensory dysesthesias on the left, on the ipsilateral side of the face, and opposite, the patient will have a hemisensory loss. Patient would have a characteristic hoarse voice, hiccups, the patient will not be able to swallow. The lateral pons, patient presents with a vertigo and sudden onset deafness. This is again medical emergency, because sudden onset deafness and vertigo can also be from the auditory branch, which is supplying to the ear. The patient needs to have a high dose methylprednisolone. But if the patient has got a facial weakness as well, apart from that, then it localizes into the brain rather than into the artery, which is supplying to the ear. So ataxia, if the patient presents with an ataxia, it could be a superior cerebellar or a posterior inferior cerebellar artery most commonly, and it is frequently restricted to the cerebellum. ICA is very rare. Superior cerebral artery, if it is there, patient also has severe dysarthria. If the patient has vertigo, then we know that it is from the pica or the ICA. If it is from the pica, as I said, it could be a lateral medullary syndrome. The patient would have an occipitocervical headache, would have severe vertigo, nausea, nystagmus, ipsilateral lung and gait ataxia, and also dysphagia and hiccups. A patient sometimes may present only with a vertigo and gait imbalance. So ataxic syndromes characteristically is restricted to the cerebellum. Apart from the ataxia, according to the cranial nerves, whether it is a third cranial nerve, into the midbrain, sensory symptoms into the thalamus, pontine lesions with facial weakness into the pons, lower cranial nerve weakness, unable to swallow, dysphagia, hoarse voice, hiccups, nystagmus, headache, pica, that is into the lateral medullary syndrome, that is medulla. So in the emergency itself, we can make out where the lesion could be so that it helps us to channelize our treatment. So basilar artery strokes are catastrophic. Patient usually presents in a comatose state. If 50% of premonitory symptoms and signs are there, they're extremely non-specific. The patient can just have paresthesia, a little dysarthria, some amount of weakness. Some patients have got pathological laughter. So we have had patients who said that before the patient became unconscious, the patient was laughing unnecessarily, and then he became unconscious. Patient has pseudo seizures. They are not typical seizures, but they just have this tonic spasm. They just go like this. They just go like this, and then they become unconscious. And then there is an locked-in syndrome and coma, because the basilar artery, we know that it is a center. Both the vertebral joint becomes the basilar, and then it supplies to the PCA, that it supplies to both pons, midbrain, and to the rest of the brainstem areas. So there is something called as a lacunar syndrome. Lacunar syndrome means lacunes, that is small areas, less than 5 millimeters areas of the brain. When they're involved, they produce characteristic deficit. If it is pure motor, that is no sensory involved, no speech, no language involved, it is in the pons, it is in the corona radiata, it is in the internal capsule. So patient presents with this, you know that 1, 2, 3. Am I looking at any of these 3? Sometimes the mathematics can be wrong and you might find a cortical lesion also, but then in most of the times, it is purely into this lacunar syndrome. If it is a pure sensory, just sensations, then it is usually the thalamus and very less frequently in the coronary, but is mostly in the thalamus. If a patient presents to you one side, hemiparesthesia, severe pains on one side, sudden onset, then it is a thalamus and less frequently the corona radiata. Sensory motor. The patient also has a motor weakness, upper limb, lower limb, similar amount of weakness, and also has sensory. That's so it is a thalamo-capsular area that is involved. That is the thalamus and the posterior limb of internal capsule. There's something known as a dysarthria, clumsy hand syndrome. He's not able to use his hand properly. It is clumsy. So maybe okay, but it is clumsy. He's not able to pick up properly. It's more of an ataxic point, but it is more in the distal, and his speech is bad than it is in the pons. So you know that pontine lesions, brainstem lesions can progress very fast. So you know you have picked up a dysarthria, clumsy hand syndrome. You should be extremely careful. And then there is this ataxic hemiparesis, that is the patient has a weakness, let us say, of a 3. But then even if it is a 3, if you're asking him to do a finger nose finger, you can see if you kept it like this, still it is going off like that, then it could be in the basis pontis, internal capsule and coronary radiata. And as I said, severe flinging movements, it comes like this and it keeps moving his hand, then it could be in the subthalamic nucleus. Yes. So basically you see they are more of lenticulostriate arteries. All of these lacunar syndromes are lenticulostriate arteries, that is, end-on arteries. They are not the large peripheral, the end-on arteries. They are not these, so they are the deep perforators. They are not the lenticulostriatus. So deep perforators, basically the lesion when we have a pure motor, we have a pure sensory, we have a sensory motor, or we have a dysarthria, clumsy hand, or we have an ataxic hemiparesis, then we know that the diagnosis, the channelization of the investigations should also be to that extent, because they are mostly hypertensive, either diabetic or hyperlipidemia, age-related atherosclerosis in these patients. So we would probably not chase a cardioembolic cause for these patients to a large extent, unless we find that the patient has got multiple, as I said, multiple areas, silent infarcts also present. I think I will take 1 or 2 slides here and then wind up for this session probably. There is something which you would hear on the rounds as spoken as watershed infarcts. They represent 5% of all watershed infarcts. There is a cortical water, there is a border zone infarct. That is, it is between the ACA and the MCA. This is between the PCA and this is MCA. This is the internal border zone, that is between the MCA and the Lacunar syndromes. So these watershed infarcts are the ones which are a little tricky because they would have symptoms of either ones. And these are usually because of vessel occlusion, which tend to produce these watershed infarcts. And here we may not be able to judge from the syndrome itself how we would be able to make a localization, and it can be a little tricky. But then it definitely tells us after the scan that we need to check on to the large vessels in these patients. That is, we need to have a carotid and vertebral Doppler in the same sitting as we are having an MRI scan, because it usually represents a large vessel occlusion. So these patients could be having a systematic system in the hypotension or unilateral in the cases, as I said, a carotid severe occlusion or stenosis. Sometimes deep anterior watershed infarcts, bilateral, they may just present as a man in barrel. Bilateral infarcts, bilateral ACS, that is bilateral proximal. We have heard ACA presents with bilateral, with a distal lower limb, as well as a shoulder struck. So you can imagine if the patient's bilateral shoulders are gone, he just presents like this. And he's just a little mute, he doesn't talk much, and he could be incontinent, and he's ebulic. So a man in barrel syndrome, sudden onset, urinary disturbance, and slow ebulia, one should suspect whether the patient has got a watershed infarcts of the deep anterior white matter. Posterior infarction, as we said, for Balint syndrome, bilateral PCA territory infarcts produces a cortical blindness, and with the Balint syndrome. I suppose we'll call it here because there are a lot more to be discussed, Aishwarya.
It's okay, ma'am, if you continue.
You can continue? Yeah.
Yes, ma'am.
Yeah. So there are all of these syndromes, these names, why I'm putting it out for you, because at every point of time in your clinics, if you're posted in the neurology department, you would keep hearing this, and it should ring a bell as to what it implies and how the physician should be reacting and responding to that particular symptom. There is something known as a limb shaking TIAs. It's very important for us to know if a patient comes into the emergency and he says that he has just jerky movements of this upper limb and lower limbs, and they were just repetitive jerky movements. Like, let us say it just lasted for 20 seconds, it just lasted for 30 seconds, and then it resolved on its own. And he comes walking into the hospital. He says, we ask whether you lost your consciousness. He says no. We feel whether he has a seizure. So we feel that it is too short to be a seizure. And the patient doesn't have a history, which is the semiology is not like a seizure. But in an elderly gentleman, this should be kept in mind that this could be a limb shaking transient ischemic attack, and this could lead to a catastrophic stroke. So you should be investigating properly Why you should be investigating properly? Because if a patient comes with a limb shaking TIAs of a 30 to 60 seconds, episodes of repetitive jerky movement of the arms and legs, if you do an MRI for that particular patient, we know that a 30-second would not have produced a infarct to him. So just doing an MRI for that patient, you might send him home. But if you have not done a carotid and a vertebral Doppler for this particular individual, he can be having a severe carotid occlusive disease. And this was a warning sign for the treating physician that he should have done a carotid and vertebral Doppler. So this is known as a limb shaking TIA, rare, but if it presents, should not be missed. There's something known as a ischemic ophthalmopathy. It is a monocular transient retinal ischemia occurring when looking into a bright light. This all of us have when we suddenly get up and move out, and if the sunlight is it's in the midday, and especially when you have the ground which is smooth and it tends to reflect, the objects appear bleached and there is a brief visual loss may follow. We can understand that it is a normal phenomenon. This is known as a retinal claudication, and then the superficial ophthalmic artery could be the one affected. That goes to say that the patient, if it is an elderly gentleman and he continues to have these episodes, not once in a while, he has these recurrent episodes, then he needs to be properly investigated. Again, I imply not only an MRI, one needs to know the patency of all his large vessels, and one needs to investigate accordingly. There is something known as a rotational vertebral artery occlusion, where the labyrinth is involved. There is a vertigo followed by tinnitus, and it is usually a branch of the anterior inferior cerebral artery infarction. Sometimes the patient may present just with a drop attack. The patient just falls down. There is a sudden loss of postural tone without apparent loss of consciousness, vertigo, or other sensation. There are several other causes which can produce this sudden loss of postural tone. We know that they could have a catatonic spells. But then if we are seeing this in an elderly patient with a lot of risk factors in that particular patient, one should be very careful and should get the patient appropriately investigated for a possible vertebrobasilar insufficiency as a TIA. Sometimes the patient presents in only coma. So in this patients presenting with coma, it is one I said, it could be the basilar artery where the pons, midbrain, and all the posterior circulation is completely affected and presents with that. Patient could also have a thalamic lesion. There is an artery of Percheron, which tends to, like I said, in the ACA territory also, if there is one artery which is supplying both the vessels, then the patient can develop a corpus callosal infarct. In the same way, if the patient has got a bilateral thalamic infarct, if you see on the scan like this is known as an artery of Percheron infarct, because that is one side of the PCA is tending to supply to both sides of the thalamus. So this again presents with a severe loss of awareness and can manifest in a state of coma. There are some videos, but obviously I can't show them on this. Patient presenting with only agitation and delirium, one should be very careful. If you have taken a proper history and there is no history of a substance abuse, there is no alcohol withdrawal syndrome, there is no suggestion of a fever which could suggest an encephalitic process in an elderly person who presents with a sudden agitation and delirium, or with any other patient, one should keep a right hemispheric infarct. The patients with temporal lobe infarcts and also hippocampus amygdala and the perirhinal cortex, the patient's only presentation would be agitation and delirium. However, if it is a left side, the patient, if we closely monitor and talk to them, they could also have a Wernicke's aphasia. Sometimes the patient presents only with isolated cranial nerve palsy. You could see in this elderly lady, you can see that the patient has got a left third nerve palsy. And if I can take your attention to the midbrain here, you can see there's only a small dot. So we have presented this as a dot and drop sign, that there was only a small dot, and that is where the third cranial nerve emerges. So in an elderly patient, if the patient is a diabetic, patient's presence with a third nerve palsy, all of us know that the patient can, in an uncontrolled diabetic, can present with a mononeuropathy, especially the third or the sixth cranial nerve in an uncontrolled diabetes. But in some patient, one should be very careful. They could also be having an isolated small infarct in the midbrain area. Why it is important? Because if you miss it out, the patient can miss out a stroke treatment. You can see this. ముక్కు చూడండి, ఈ ముక్కు ముక్కు చూడండి, పక్క చూడండి, ఇక్కడ ఇక్కడ. You can see he's not able to look onto the left side here. That is a left lateral rectus palsy. That is characteristic of a pontine lesion here. So that's the area. That is the sixth nerve, and that's the area on the brain that is involved. I'm not sure whether I should continue, Aishwarya. There are a lot of syndromes still pending. We should call it a day.
Okay, ma'am, sure.
Yeah, I think because it will be too much, because if we keep talking, we could take it from here and wrap it with one more.
Sure, ma'am.
Yes.
Thank you, ma'am, for delivering such an informative session. Ma'am,
Aishwarya, I'm not able to hear anything.
Hello, ma'am.
Yeah,
Hello, ma'am.
I can hear you, Aishwarya.
Yes, ma'am. Network issue, ma'am, at my end also.
sorry, ma'am, I had some network issue. Can I continue? Ma'am, so we have few questions. So can we take them up?
Ma'am, is Vaishnavi audible, ma'am?
Yes, she is.
Okay. Ma'am, so can we take up the questions?
Yes, please.
Ma'am, we have few questions as on YouTube as we are streaming live. Like, what is the NIH stroke scale?
So National Institute of Health Stroke Scale is a validated stroke scale which gives us an unanimous numbering to the patient to tell us what is the severity of the stroke in the patient. So it also helps us to know if the patient's stroke has progressed, because every individual doctor who would come and assess the patient might find that the patient is better or the patient is worse. And another important aspect of an NIH stroke scale is that if the patient's stroke scale is very severe, let us say if the patient has a 17 stroke scale or something, then the patient might not be eligible for a thrombolytic therapy as well. So if I assess the patient with an NIH stroke scale, it has got points, several points, of which each point has got 4 subheadings to 4 to 5 subheadings, in which the visual, the comprehension, the speech, the ataxia, the motor weakness, the sensory weakness, and everything is assessed and a point is given to the patient. After the thrombolytic therapy also, the NIH stroke scale helps us, because it tells us after the NIH, after the thrombolytic, the patient has improved or the patient has deteriorated, while we are thrombolizing the patient also, whether there is, so how does it help us is like if for XYZ doctor has thrombolized the patient, has given an NIH stroke scale of 4, And if the doctor has gone away, but if the next doctor also comes and sees it, there is a validated scale there. It's like a Glasgow coma scale. So you are not going to miss out, or each individual self-assessment is not going to be different. It is going to be a universal pattern of assessment for that patient. Tells us the severity, where we can help the patient, whether the patient can be thrombolized. Post thrombolysis, whether the patient has improved or deteriorating. Also in critical strokes, whether the patient's stroke has increased, whether the patient has got new and fresh symptoms, because again, as I said, there are pointers to it. 42 would be a very severe stroke scale. 2 or 3 would be a very low stroke scale, would help us to judge whether we can thrombolize the patient in an acute situation.
Okay, ma'am, thank you. And there's another question. What is the difference between Anton syndrome and Charles Bonnet syndrome?
They are different in that's another. These are the ones which I was trying to take to you, and I suppose I will take it in the next class with a lot of pictures are there. I don't want to miss that. Yeah.
Okay, ma'am, sure. Ma'am, I would like to hand over this to my teammate Marina. We also have few questions from registration form, ma'am. Over to you, Marina.
Okay, so the next question is, why do we see majority of patients having posterior circulation stroke experience severe headache?
So the posterior circulation strokes, it is usually a brainstem infarct. The brainstem infarcts, if the patient has got cerebellar infarcts, usually that is in the area where it compresses on the fourth ventricle. So that becomes more of an area where our radars also become very alert, because any of the patient who has got a posterior circulation with headache, that means the patient has got a compression on the ventricles. Where the ventricular system is getting compromised, that means the hydrocephalus is impending. And any hydrocephalus impending means it is a time where a surgical intervention has to be done. So cerebellum affecting to the fourth ventricle. In general, posterior circulation, which has got a carotid cavernous dissection, or it has got a vertebral artery dissection, or in some syndromes where the thalamus, let us say the posterior circular artery, PCA territory is informed. I just showed you the artery of Percheron. If it is on both sides, then we can see that the third ventricle gets compromised. Again, there is a hydrocephalus.
Thank you, ma'am. The next question is neuroprotective agents which are used in stroke, and when should they be used?
So the name itself suggests that they are neuroprotective in nature. If we would see the literature and the research which has gone to it, there are not enough evidence for us to suggest and tell that they can be used in patients. But they can be used, I should say. It is different thoughts for different neurologists, I would say. If at all it is used, it should be used in the early stroke symptoms. A protection, that what we are trying to do is that we are trying to see that the oxidative stress at the cellular level is minimized, so that the extent of the damage and the extent of the brain death, excess of the cellular damage, is as less as possible. That's what the thrombolytic therapy tries to do. That is what the neuroprotective drugs also would try to do. In certain cases, if the patient has got a left hemispheric infarct, especially the MCA territory in which the patient has got aphasia, for a period of time, it has been suggested that the patient can also have some neuroprotective drugs like pyricetam, where it has been seen in cases that the speech and the language can be modified. However, they are not carried on for a long period of time in the acute to the subacute stage, and then there's tablets from the injectables, they are switched on to the tablets, and then they are stopped.
Thank you, ma'am. The next question is a management of hypoglycemia in stroke patients.
A management of a hypoglycemia in a stroke patient is as a regular hypoglycemia for any other patient. There is no difference in a management of a hypoglycemia. Only thing one should keep in mind is that if the patient has got a hypoglycemia, whether it is a stroke mimic. So whether the hypoglycemia has initiated the stroke. So in some cases, there is we have the we have shown the corpus callosal lesions. In that, in the hypoglycemia, the patient would have just thought that area which gets involved, and it is usually not a stroke. It is a vanishing syndrome, and you would have the scan done after probably a period of 3 weeks or so. You would find that the lesion just vanishes. That was just a transient sign, which is in the posterior corpus callosal area. Management of the hypoglycemia is the same as for a hypoglycemia in a patient who doesn't have a stroke as well.
Thank you, ma'am. Next question is, which are the common areas for lacunar stroke?
That I showed you the one slide for you. That is the lacunar syndromes. And I would suggest that is the pure motor, the pure sensory, the ataxic hemiparesis, the dysarthria, clumsy hand syndrome. And that goes into the internal capsule, the pons, the thalamus, and the corona radiata. These 4 areas are the most characteristically involved in the lacunar syndromes.
Thank you, ma'am.
Ma'am?
I would
Ma'am,
like to, sorry, yeah.
Yes, ma'am. Yes, ma'am.
So I would like to continue with this because there were a couple of questions and the talk was not over because it just takes another 45 minutes for the rest. And if people are interested, we can continue with the same talk and merge it with some small one as well in the next session. Is that okay, Shvirin? We can discuss the date.
Ma'am, could you please repeat? Your voice was breaking at my end. You want to continue the talk right now?
No,
I couldn't hear you properly.
it's a little late now. I'm saying that in the next session, we would continue with the stroke syndromes because the talk is not yet over. And if we finish well before time, we will have something else slotted along with it. We will take these stroke syndromes in the next class as well. I would like to complete it.
Yes, ma'am. I think Aishwarya is having some issue, but we won't mind, family community won't mind to have another session with you, ma'am.
Yeah, and they will just finish up the stroke syndrome so that I know that the PharmD community has understood stroke.
Yeah.
Yeah. Then
Yes, ma'am. Thank you so much, ma'am. Like, whenever you're free, just let me know. We'll plan the part 2 for stroke syndromes. Like,
thank you very much.
yes, ma'am. Thank you so much, ma'am. It will be a great opportunity for all of us to, it's a great opportunity for all of us to learn stroke syndromes from you. Like, it's one of the major part in clinical decision making, and it will help us understand stroke better.
Yes.
Okay, ma'am. So this brings us to our end of a session. I would like to thank all, also the ma'am, for taking their valuable time for this session. And we'll see you in another session too, ma'am.
Thank you. Stay safe.
Yeah.
Stay healthy. Bye-bye.
Yes, ma'am.
Bye, ma'am.
I'd
Thank
also
you so
like to
much,
thank
ma'am.
all the participants who have joined us for this session. The feedback link is posted in the chat box. Kindly fill up. Thank you, everyone.
Bye.